All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's topic is about the relationships and the education and the interactions between respiratory therapy and palliative care. Our format for today is going to be two parts. We have two perspectives to offer, one research and one bedside, and then we'll open it up for some questions. To help us with this today, we have two fabulous guests. So first, we've got Dr. Shauna Strickland. She is an association professional and registered respiratory therapist. Shauna has worn many hats in her field with over a decade of clinical care, as well as roles in ethics consultation, in higher education, and clinical directorships. She currently serves as the Associate Executive Director Programs at the American Epilepsy Society, where she leads the clinical, research, and educational divisions, and she is an adjunct faculty member at Rush University. Welcome, Shauna.
Thank you.
And second, Sarah Bazelak is a registered respiratory therapist, also with over a decade of clinical experience at the bedside. She is the Respiratory Care Education and Quality Coordinator at Froedtert Hospital in Milwaukee. And congratulations to Sarah, because she'll be earning her master's degree in respiratory care this year. So welcome, Sarah.
Thank you.
And I will simply hand the mic over to you two.
Wonderful. Thank you so much for joining us. Respiratory therapists are, I believe, even today, one of the best kept secrets in healthcare, because respiratory therapists are interactive with their patients from all along the trajectory, the life trajectory and the disease trajectory and health and wellness and all kinds of places. And so this palliative care piece for respiratory therapists, I think, is an untapped potential. Respiratory therapists work with a patient from the onset of symptoms, sometimes in clinic settings, sometimes in acute care, urgent care, emergency care, first admission for a disease process. And if you ask respiratory therapists if they participate in palliative care, they will say no. And I think that that's a big misconception for respiratory therapists, because they are interacting with their patients every day. They're asking about their comfort level. They're asking about social issues. They're interacting with their patient, and they're getting a lot of information and reacting to that information. But the phrase palliative care, I think, is a phrase that puts them off and makes them say, oh, no, I'm not part of the palliative care team, quote unquote, or I'm not part of the palliative care plan. So over the past decade or so, maybe a little longer, I'm getting up there in age these days, the years kind of run together, but looking at palliative care and how the respiratory therapist identifies in that space has been an interest of mine. The research is not great, because, again, respiratory therapists don't think that they're part of this plan, this care delivery system. So the research into respiratory therapists and how they interact is pretty small as well. A lot of respiratory therapists have a poor understanding of palliative care principles. Again, this is from that aspect of, I work in critical care, I work in acute care, I know how to deliver respiratory care, but I perceive a disconnect in between, this concept of palliation with regards to respiratory care. So last spring, I guess it was, I am a research mentor to some students at Rush University upon occasion, whenever they need such a thing. And one of the projects that we did last spring was survey respiratory therapists about their perceptions of their role in palliative care. Very small survey, very small sample. I think people are kind of surveyed out, that's get one more survey that comes from anybody is low on the priority list. But what was interesting was 91% of the respiratory therapists we surveyed said that they had experience in palliative care at the end of the patient's life. So from my perspective, I think there's a lot to unpack there anyway, and I'm going to put that off to the side. But when I read that statistic from the information we gathered, I thought, this is an aspect of patient care that respiratory therapists are consistently involved. They are identifying, I am there with the patient during this time. The problem is that only 42% of those people who were surveyed said that they felt comfortable participating in palliative care. So a little bit further digging found that only about 20% of those folks who responded to the survey actually received palliative care training in their respiratory care entry to practice education. Now, there was a large trajectory of ages and years in the field on our survey. So if I reflect back to when I went to respiratory care school, which was a long time ago, well before Sarah went to respiratory therapy school, palliative care, I don't even know that we said the word palliative care, back in the day. So definitely I am in that camp of I did not receive any palliative care education. Those who are more recently graduated probably have something. At Rush, I give a 3-hour lecture once during their master's degree program, which is great and probably more than most programs give. So the prioritization of information in the entry to practice education is clearly not on palliative care. But beyond that, there are still folks that are able to take continuing education, interact with their palliative care team or their ethics committee at their institution. But unfortunately, it has to be fairly intrinsically motivated. There isn't a lot of mandated continuing education on this topic. So it would have to be from someone who was interested in learning more about the topic. And so one more little deep dive into this research is that we found about 45% of those surveyed felt included in the palliative care plan at their facility. So I think that's an opportunity. That's a huge gap to look at this profession that has a great deal of potential with patient care and a great deal of potential with negotiating the space with the patient and the constant communication they have with them, and impacting positively that palliative care plan. And before I turn it over to Sarah, I will say that there was a survey in Canada with Canadian respiratory therapists about 2 years ago, and 91% of the respiratory therapists they surveyed in Canada were interested in formal palliative care training. So I think that the opportunity is there. I think that the need is there. I think that the desire to help is there. And now we just have to figure out a way to connect it.
I would definitely agree with you, Dr. Strickland, on those items. I think that what we've run into at the bedside perspective a lot too is what I oftentimes hear Martin talking about too is maybe that misnomer or misconception of what palliative care is. And I think when I reflect on some of my staff with respiratory and peers, and even myself initially, we think of it as end of life. And I think that's what we run into often. And like Shauna was saying, we see all aspects of life. So we're there, in the delivery room, we are there at the end of the life, removing mechanical ventilation or participating in cardiac arrest. So people just have that assumption that the palliative care, when we hear palliative, oh, they're going to be end of life. Now we're transitioning to comfort care, but not really truly understanding what palliation is. And, really some perfect examples I think back on too is staff just not even understanding that maybe a patient is, do not intubate, do not resuscitate. However, it does not mean that they don't want to be cared for. They don't want to still feel comfortable. And so just always kind of bringing it back to really emphasizing that point for them is that we are still caring for the patient. We can still do therapies or interventions that are making them comfortable. So maybe that non-invasive is helping them feel comfortable. So putting that BiPAP on, helping them catch their breath, that is helping them feel more comfortable and at ease while they are going through, certain circumstances. Or, we were addressing pain management for them. We have a part in that too. So some of the therapies that we can do are going to help with reducing pain. We can coach on those aspects too. So just kind of being aware of that. And I would definitely agree that when I think back when I graduated from my initial degree, which was an associate's degree, it was a very sweeping topic. And it was too really focusing on more the end of life perspective versus what we could be doing in our everyday practices for palliation. And just having a greater understanding of what it means when palliative care is interacting with the patient. One of the experiences I had as a staff therapist actually was at University of Iowa. I worked there for a year and had some really great experiences. And there they had a area where we had a unit for palliative care. And sometimes that was looking more at the end of life situation. But even there, they were really great about involving the RT in the process of how we were going to be looking at getting that patient towards their end of life, or what we were doing to help with their comfort cares or palliation. So we were really part of that team making those decisions collaboratively. And I think that really helped. They did a good job too of really trying to engage and getting the therapists a better understanding of what the role is for palliative care. And I think we have a lot of opportunities, kind of like what Dr. Strickland was saying, of getting that out into the broader perspective and hospital setting and acute care setting, clinics. So I think there's a lot of opportunity, and we focus on largely work of breathing, helping patients with any kind of respiratory complications, but we do see other aspects too. So I think maybe engaging respiratory in some of the care planning might be a nice thing early on. And even when we are moving at maybe that end of life perspective, having respiratory being engaged with the family discussions or the patient's planning. That way we can kind of help better understand, first of all, what the plan of care is and how we can maybe be more successful on it. There also might not be that hesitancy of, you want me to start decreasing the respiratory rate? You want me to make them hypercarbic? Sometimes that's a plan I hear, but I think having that understanding of kind of the rationale that we're trying to make that patient comfortably, be able to come off the machine without having work of breathing or feeling that air hunger. Some of those types of different approaches we could do.
Wonderful. All right, we'll open it up for some questions, and while we do that, I have a few. We give people a few moments. So I want to start by reading a couple of notes I've been taking over the last couple of months, and these are pretty just blunt notes. And then you can pick whatever you want to comment on as part of this. So how do RTs, and this is just more me just thinking out loud about this. So how do RTs feel about their role in end of life and terminal extubation? I mean, do they feel like they are bringers of death, and yet we don't involve them in the actual conversations of these decisions? And then that makes me worried. Are they left grieving alone? And I know that RTs are working to try to raise their education level, right? They're working towards becoming clinicians, right? Not just somebody who comes and removes a tube. And I'm not saying that's what you guys are, but just oversimplifying. And so now more than ever, should we be involving RTs in some of these major decisions and family meetings in the ICU? What do you make of it? Any of those thoughts?
A lot of questions.
Yes, of course respiratory therapists should be involved. I would say, based on my experiences, I remember the first time I had to remove a patient from a mechanical ventilator and a terminal extubation. I understood the theory. I was not involved. Respiratory therapy at the time was not involved in the hard conversations with the family, but there was a team debrief prior to removing the patient. There was a child in a cardiac ICU who had an extraordinarily challenging course, and unfortunately was just not going to resolve. And my preceptor, I was an orientee at the time, my preceptor did a very nice job of walking me through the steps before we ever walked into the patient's room. Technically, everything went very, very, very smoothly. The parents were at the bedside. Everything was coordinated. Everything went really well. So from the outside looking in, yeah, it was great. It wasn't great. I mean, I'm not saying that the death was great, but everything went according to plan, and it was fabulous, until I walked out of the room, and it hit me that that my actions terminated the life of that child. And not that I felt like I was the cause, right? I mean, the disease was the cause of the child's death. But it was hard. It was hard to reconcile. It was very hard to reconcile. And my background is predominantly children, so almost all of the terminal extubations I've been involved with have been children, and they're very, very challenging. So yes, I absolutely think that the respiratory therapist should be involved in those conversations. The broader conversation of here's where we are. Do we see resolution? Does anybody have a any objection to this plan or anything to work on? I absolutely think that at any point, the respiratory therapist should be involved in the care plan, whether we're talking terminal extubations or not. But I also think that that would go a long way in helping the respiratory therapist understand the implications of that action. And I am not simply walking into the room to turn off a machine, silence a beep, and walk out, right? That I am an integral part of that care team.
Mm-hmm. Yeah, you've touched on many different points there, Martin. So I think kind of just focusing first on the comment of the death bringers. You're using some of my words that I've used. So I find that sometimes our staff feel that sometimes we're getting called upon when it is a situation where we're removing a patient from mechanical ventilation, where they have been not part of the conversations. They don't know where maybe some of the knowledge gaps might be on what the process is going to look like, what the patient is going to appear like after we've removed the breathing tube. So sometimes we feel like we're kind of being put onto a little island of, okay, I have a pretty big task here on not only trying to set the stage for the family and the expectations of what's coming, but then also I have to set myself up for what I'm going to be walking into, because I always like to leave the option for the family. I give them the understanding of what the process is going to look like. So what the procedure of removing the breathing tube is going to look like, turning off mechanical ventilation, what we're doing to help make your loved one feel more comfortable. But then the reality of what that patient may appear to them as, so being very air hungry, hearing secretions in their upper airway, breathing very fast and hard. Some of those things are things that they need to know. Some patients, families opt to stay in the room. And then I need to set myself for the understanding that I may see a lot of emotional toll happening during that process. Everybody takes it a little differently. And then, what do I say after I take this out? Because certainly this is somebody's loved one, and I just took away their life support. And now I'm going to say, all right, what do I say? Have a good day? That's not what I'm going to say. So just trying to figure out how to interact with family, and recognize that the patient may still be actively alive at that moment too, and trying to make sure that we're engaging with the family and the patient at the same time. So it's just a lot of emotions all at once. And I think that sometimes people don't really recognize when they're putting in, an extubation order or remove mechanical ventilation order, what that means for the respiratory therapist. So kind of bringing it back again, the ask of, in involving us earlier on with those discussions with the family. So we kind of know what the expectations are, what the understanding is for the family. And then really making sure we can touch on the things that are helping them with kind of taking this information in and processing the whole situation. I think too, when you made the comments about, our level of education and where that's going, when we kind of look at where we're at for, instance, the United States mortality, what are our highest level of diseases bringing mortality? We're seeing a lot of cardiopulmonary diseases that are those top levels. So we're seeing more and more death more frequently, or more complicated disease processes that we're going to be helping manage from a palliative level for maybe years. And so we need to continue to elevate our understanding and our education background. And because things are becoming so complex, that is a ask from our national society to continue to develop ourselves. And it's necessary because we are coming up with so many different tools and interventions that we can help support with. So yes, we are definitely looking at trying to elevate the career and have that understanding that we need a very high level, high functioning clinician because of the complexities of the medicine.
So So I give each of you a magic wand, because palliative care has all the magic wands and the crystal balls, and you're able to create one change, one thing that could just happen. What would you do to make this better?
I think for at the bedside, I would love to have the questions come of, this is going on for our patient. This is kind of the dynamics that we're seeing. We would love to have you sit down with the family and the team, so we can kind of talk through where we're at, what we're seeing, what we can offer, and how can we meet what your goals are for your care. I think really bringing it back to the family. And one of the things that we're really trying to do with respiratory as a profession, I think a lot like palliative, we are very finite resources. So these types of situations are of high value, high quality for a patient's care. We want to take the time to have these discussions and be part of that discussion, that planning. These need to be where we are focusing. We are becoming very high-level clinicians to support these types of conversations in complex cases. So just engage us early, find out how we can help with the resourcing, and really make that level of care. I think people sometimes don't realize that we are having so much interaction with the patient and their family too. So that too is where we might be able to help with kind of having those conversations sometimes with a bedside clinician perspective, and help make the family and the patient a little bit more comfortable with the conversations too.
My magic wand would be a little earlier in that process. I want to empower respiratory therapists to be proactive. So I want early education. I want practical, hands-on entry to practice education for palliative care, for respiratory therapists while they are learning how to be a respiratory therapist. Because I think that these principles can integrate throughout the care that the respiratory therapist provides, whether the patient's at the end of life or newly diagnosed. That palliative care application across the patient's lifespan, I think that if we can get the respiratory therapist as new students to understand how they can apply these principles throughout, and then empower them to have those conversations, I think that we could achieve a lot.
I see we have a couple questions. Perfect.
Can you hear me?
We can hear you.
Okay, hello. Thank you. Thank you so much for this. I'm on a more of a hospice based, trying to facilitate discharges from hospitals, and it's just that the challenge we all deal with, right? That mostly with these end stage COPDers and stuff, and we get trapped in that high flow oxygen bubble, and the family wants to get home, patient wants to get home. Any advice on language that you use for overall goals of care, specifically to the numbers, trying to get them this unique population who are so used to looking at the numbers to look at the overall picture? Just interested in any language that you've found beneficial.
I think just trying to focus on when they're feeling more comfortable, what they're looking at. We want them to think more of when they're not thinking about their breathing, when possible. So just bringing it back to what are you finding is helping you with keeping your mind off of your breathing? Because certainly those on-stage COPDers, that's all they're thinking is like that constant breathing. What is going on? How anxious I'm feeling, and trying to find out what is helping them with that anxiety too, and really focusing not so much on the numbers. Take away the pulse ox, don't even look at it, because that's not helping you right now. And figuring out what breathing techniques are helping, what activities are making you feel more comfortable. Just focusing more on what's going on inside, not looking at the numbers. It's so hard, especially for our patients that are very chronic, or very used to being on those high level support items.
Yeah, I second that, Sarah. I think it's a hard transition when you've had a disease process that you've managed for the past 10 or 20 years. And with every visit, the first thing the clinician does is take your pulse oximetry. And so you're very focused on those numbers because you've been trained to be focused on those numbers and understand what that means for you as a patient. And so to transition to something that's not numbers based is very, very challenging. So I would agree, let's talk about how you feel. Let's talk about, let's ditch the the device and let's talk about, can you talk without, can you say a full sentence without stopping every other word, or those kinds of things, and focus more on the physical presentation.
Yeah, I had a terminal extubation last week of a patient with a hypoxic brain injury, and the family's main concern with extubation was, well, how much is he going to breathe after we extubate him, and will it be enough to, for him to survive for a certain amount of time? And I think the RT just happened to be in the room at the time, so we could talk about how much is he breathing over, what are his tidal volumes like, and the RT was able to share like that it's a low amount of tidal volume, and that's with the pressure that we're giving him. So could kind of give a better idea. And it did make sense. Like, I wasn't going to be the one that was there for the actual time of extubation with them. The RT was. And I thought it would also be nice, like maybe the RT can ask them what exactly do they want that to look like? Like, do they want to be right at the bedside? Do they want to be at the other side of the curtain? Logistics like that, because they're the ones that actually are going through that with them.
Yeah, and you hit on a couple of points that I really try to train our staff with too, is I like to give as much of the options to the family, or if the patient's able to interact with us, I really like to try to empower them to have as much of the, decision making as possible. So even things like oxygen, do you want oxygen on after I remove the breathing tube? And I'll go through, the possibilities, what that would look like. So, maybe if I put on oxygen afterward, there is the potential I could be prolonging life. However, there is also the possibility it may make the patient more comfortable feeling that flow coming at them. So I like to give them both of the sides of it and really let them decide on that. I also really like to emphasize that, we're going to pre-medicate for those air hunger symptoms, and really working with the nurse on making sure we have that timed well too. And I think that that's one thing that people sometimes overlook. They're like, oh, the nurse is giving medicine. It's like, yes, but timing is everything. We want that to have enough time to make an impact for the patient. So making sure that we are coordinating well with our teammates, making sure we optimize the patient's care, and really setting the scene is so important for the family, because it's already such an anxious feeling of, did I make the right decision? Like, am I actually killing my loved one? Am I the one doing this? So helping them understand that is not what's happening. We are really trying to make sure that the patient is comfortable. We're giving them medication. They are going to be feeling comfortable. We're looking at different signs to help make sure we keep that comfort path going. But what you could see, and it is very likely, is that they might start breathing a little faster and shallow. You will likely hear some secretions that are in their airway or in their large airways. And that is all perfectly normal. And what we're going to be doing is just trying to make sure we stay very comfortable with their medication. That way they are not feeling that pain or air hunger. Their body is just demonstrating those behaviors still happening.
All right. Well, thank you, Shauna. Thank you, Sarah. Any last piece of wisdom to offer us before we conclude for the day?
Incorporate your respiratory therapist wherever you can.
Mm-hmm. And don't assume that they know palliative. And they probably are well practicing a lot of the things that we could be doing, but they just don't understand that that's what they're doing. Often they're thinking it's end of life that you guys are working with and that they're doing, but we're doing so much more.
All right. Well said. Thank you, folks.
Thank you.
Thank you. Have a great day.
Bye.